Hello and welcome. The number of COVID-19 cases are beginning to peter off or plateau in some parts of India now, but in other parts they continue to rise, as do the number of deaths, which of course there are two sets of numbers. One is the documented numbers and the non-documented numbers, and that distinction is quite clear now. However, the other interesting issue that's coming up now, and a serious one, is really the kind of after effects that we are seeing in those COVID-19 patients that have been treated and have recovered. Now, it is obviously known even to lay people like me that there is a COVID-19 after effect. But could those after effects also be caused by medicines, or perhaps in some cases the overdosing of those medicines? And what might those medicines be? And what is the damage that they could have done, if damage is the right word, in the last 1 year? Remember that many of these medicines were administered also because there was panic. Maybe people were looking for a quicker response and therefore had no choice but to administer them. But today, as we stand here in the middle of May 2021, in the second wave, hopefully towards the end of the second wave, and preparing for the third wave, what are the lessons that we can take going forward? So to understand and to maybe throw some light on this issue, I'm joined by two well-known experts, Dr. Rajani Bhat, consultant pulmonologist based in Bangalore. She is an American Board of Internal Medicine certified doctor in pulmonary diseases and critical care from the Albert Einstein College of Medicine in New York. Dr. Lancelot Pinto, based in Mumbai, consultant pulmonologist and epidemiologist at Hinduja Hospital, an MBBS from Mumbai, also an MSc in epidemiology from the McGill University in Montreal, Canada. Thank you both for joining me. Dr. Bhat, let me start off with you in a manner that we can explain to those who will watch or read what we are talking about today. What are steroids? Since steroids are those medicines that have primarily been administered, or one of those medicines that have been kinds of medicines that have been administered and leading to some side effects which may be now more dangerous than we thought.
Steroids are really an external or an artificial form of a certain kind of chemical which is produced in our body itself. We have certain endogenous steroid-like chemicals that are produced in our body in response to stress, like cortisol. When our body in COVID infection, what happens is that we initially have a phase where the virus is replicating and growing in our body. But what we've noticed in this infection is there's a very strong element of inflammation in the second week. Steroids are medications which are used for reducing inflammation. They come with the potential side effects of lowering your immunity, raising your sugars. So they're not medications that one gives without any thought and caution. In the past, steroids had a really bad name. So even as pulmonologists, Dr. Pinto and I sometimes have struggled with telling patients who actually need steroids that they need them. So it was a matter of abuse several decades ago, followed by fear and caution in the general public, so that even the required use of steroid required a lot more counseling for us. What we've seen happen with COVID-19 has been that, especially with the publication of certain reports of the beneficial effect of steroids in moderate or severe cases of COVID, in those who require oxygen or ventilatory support, has also loosened up people's fears or cautions about the appropriate use of steroids. And of course, there's the problem of over-the-counter medications being available to people. So steroids are those drugs which are wonderful if used judiciously at the right time for the right patient, can be used without fear if under the advice of a physician. But most definitely, they are drugs that need to be used with caution, and should not be used without the appropriate advice.
Right. So, Dr. Pinto, from your experience, and not just your own experience, but when you look around, would you say that steroids, and if we are only talking about steroids for now, have been administered judiciously in the last year?
So unfortunately, the answer to that is no. And we've unfortunately seen the adverse effects of that happening quite rampantly. So what tends to happen typically, and it's difficult to attribute or ascribe blame to this, but I think what typically happens is that there's an individual who has high fever, which is a very common symptom of COVID, especially in the first week. This high fever is very worrisome in the atmosphere of paranoia that's all around. The person realizes that his or her fever is not remitting in 2 or 3 days. So there's a lot of panic, there's a lot of anxiety, there's a pressure on the doctor to do something. And despite paracetamol, despite the standard medications, if the fever doesn't settle, uh, that kind of stimulates, that kind of nudges the doctor towards trying to give steroids, because steroids work wonderfully at settling fever. The fever settles fantastically in a day or two. The patient's happy. Unfortunately, if it's done too early, that kind of gives the virus a free hand in terms of multiplication, in terms of growing in the body. So the typical picture is 1 to 2 days of improvement, feeling great, feeling energetic, and then when people crash, unfortunately, they crash really badly, because that's the stage at which the virus comes back with a bang. Your body's immunity has been completely suppressed by the steroids, so you don't have a natural immunity that you would normally mount, which would, for a majority of individuals, overcome the disease. So the fever in a majority of individuals would persist for 4 or 5 days, but would settle on its own on day 5, day 6. But if you don't wait for your body to take over, if you don't wait for that immunity to kick in and allow the infection to be controlled and therefore let the fever come down, if you start steroids in a haste, you suppress your own body's immunity and give the virus a free hand. And unfortunately, we are seeing this too often.
Right. So 2 questions. So therefore, you're saying that the steroid did not work in the first place. And secondly, are people accessing steroids through over the counter, or is it because they're getting this from doctors or some other way?
So unfortunately, I'm seeing this in a lot of prescriptions. So a lot of prescriptions on day 3, day 4 have steroids written on them. So it's the doctor who's clearly prescribing these. Whether that is being driven by immense pressure from the patients and their families, saying that, listen, we are really scared. There are no beds maybe for us if in case we deteriorate, and this fever is not settling. So please do something about it. Whether that's being driven by patients or a misunderstanding of doctors who've heard that steroids are wonder drugs, but have not realized that there is a nuance to that argument. I mean, steroids and oxygen are probably the only 2 drugs that save lives in COVID, right? But if you make a broad statement like that and somebody just listens to that, they might just presume that at any stage of the illness, you give steroids and they're going to make things turn around. And I think that's a genuine problem that needs to be addressed as well.
Right. Dr. Bhat, so what are the steroids that people usually prescribe and are administered, and particularly, as both of you have said, in that early stage when perhaps it should not be? Secondly, if you look at, let's say, practices in other countries, maybe the United States or the United Kingdom, what is the normal approach, particularly at that point of 2 or 3 days of fever or 3 or 4 days of fever?
So the steroids that was studied in the largest trial, which was the recovery trial, and in that they studied 2,000 plus patients who received steroids, and these were patients who were moderate or severely ill, who required oxygen or ventilators. That was dexamethasone, and it was used in a dose of about 6 milligrams, going on for about 10 days, and it did show improvement in these patients. It actually is the one drug which showed a mortality benefit in these patients. However, the same trial also showed that if it was given for patients who did not require respiratory support, who did not require oxygen, who were not severely ill, it also had a detrimental effect. So the trial was very clear in stating that there is an appropriate time and place for using the steroids in a select group of patients who require oxygen or ventilators. The other drugs of the same class of steroids that have been used are prednisone, methylprednisolone, hydrocortisone in equivalent doses. And this is part of standard treatment in many pulmonary diseases, in many rheumatological diseases. We use equivalent doses of this class of medications, which is steroids. I think one of the main issues with steroids has been this part about using it appropriately in the right case. There's also a newer study that's come out. It's a smaller number of patients, though, which is about inhaled steroids, inhaled budesonide, which is the kind of medication that we've used in asthmatics and patients with COPD. And that came from the fact that in the initial studies, they found that this group was underrepresented amongst the severely ill patients. People who were coming in severely ill, there weren't so many asthmatics and so many COPD patients. So one started looking at, were there regular maintenance medicines having a protective effect on them? So this is something that's emerging as maybe something that can help us, again, to be used judiciously and not without the advice of a doctor. When you were asking about what's different in the practices in the UK, where a large part of these studies were conducted, was that, yes, you don't have access to over-the-counter medications. Steroids are accessible only to patients who are seeking hospital care, not for those in home care, because they have a triage system where it's only home care for people who have oxygen saturation is above 94 for certain. If it drops below 93 or 92 is when they seek emergency care, and that's when they receive the steroids. So you're not able to access the drug unless you have been evaluated for the right indication, which is a drop in your oxygen.
Right. And do you think, as a quick aside to that, I mean, do you think that's possible in India? Could we do that? I mean, for instance, as one response, suppose we said that steroids would be only available to patients who are more serious, and therefore keep it only in hospitals and so on. Is that possible?
I think it would have been possible had it not been for the fact that our healthcare system is overloaded. I know that there were similar attempts once there when we were trying to figure out restriction of travel, when certain states came up with restrictions on paracetamol and antihistamines being sold over the counter, that no chemist would be giving you paracetamol unless you were, unless they were sure that you didn't have COVID. These are things that have been attempted. However, that works fine if you have adequate healthcare infrastructure for all these patients who have low oxygen. Right now, I'm sure Lance is doing the same thing in Bombay. Many of us are managing patients who are those who require steroids at home, even patients who require oxygen at home. So I think the most important thing is need a prescription.
Right.
And
Okay.
a well-qualified
Right. Dr. Pinto, can I come back to you? So, a year has passed, a little over a year between the first and now into the second wave. What are the lessons that we've learned, particularly in the way we've administered these medicines? And what are you seeing or have seen in patient behavior? I don't mean behavior in a general sense, but or maybe the after effects of the medicines that we've administered.
So I think what I've really learned is that minimalism really works in a disease like COVID-19. Being watchful, monitoring carefully, hand-holding patients, and keeping them calm while they get anxious is, I think, what doctors really need to do. Unfortunately, I see doctors completely overwhelmed and overburdened, and it's much easier to write a prescription with 10 drugs on it, where the patient feels that he or she is being served in some way, rather than tell them, listen, you don't need anything, and them feel that the neighbor is getting so many and the uncle and aunt is getting so many, but their doctor is giving them nothing. So it's been unfortunate in a way that we've had to really work hard convincing patients that they don't need anything for a disease in which they probably don't need anything. But to answer your question, I think the lesson we've learned is that far too much is being done for a disease that really doesn't need much to be done other than monitoring for most of the disease process. So if in the second, if in the second
I could
week
jump
when
in here
things,
for a second.
Go ahead.
Sure.
Yeah. So, I mean, this is something that we were in a discussion yesterday with my, peers and colleagues. And one of the things that came up is how can you send the patient away empty-handed when they come to you with great anxiety? I don't think we are sending patients back empty-handed. We send them back with advice, with our reassurance. What this needs is excellent communication and being there for the patient, which is what Dr. Lancelot Pinto was saying. This is part of our skills as doctors, to know when to do nothing but reassure, to know when watchful waiting is the most important thing for a patient. The other thing we've seen is that this misuse of medication is not just among the lay public, it's amongst doctors as well. I can tell you that I've treated my own mother and my husband, and I have not misused these medications. But I've seen that fear takes over even the most scientific of minds. And at this point, we need to be governed, and we need to be following the path of science rather than fear.
Right. So, Dr. Pinto, if you were to tell people, suppose I were to come to you and I said that I'm desperate, please give me some steroid because I read somewhere or I got a WhatsApp forward which said that take the steroid and the fever will be curtailed and I'll be okay in 3 days or 4 days. What would you tell me? Why would you warn, or how would you warn me against that?
So I would tell you that I have over a year of experience now in unfortunately seeing the other side of the story. So most people in the community who prescribe these steroids will not see these individuals eventually getting hospitalized. And I've had the experience to receive patients at the hospital who've been started on steroids too early, who've deteriorated very rapidly. What's also unfortunate is that the people who tend to mount the strongest fevers are often young, and these are the individuals who we've seen in the hospital come with in a really bad shape because they've been given steroids too early because the fever was 102, and that got somebody really anxious. So I would tell them that with the experience that we have from the past year, with the experience that most countries across the world have from the past year, We know that fever by itself is not a cause for concern in the first week. We know that the real monitoring tool is the oxygen levels, and we know that steroids work very well when given at the right time when the oxygen levels do fall down. But as long as the oxygen levels are rock steady, as long as there are no really bad lower respiratory symptoms, so if a person's not really coughing too bad, fever alone should definitely not be a reason to give somebody steroids early on in the disease.
Dr. Bhat, what kind of after effects or have you seen, particularly much after the patient has recovered, if any?
So after effects just of COVID in and of itself, especially this time, what we're observing is sometimes these lingering fevers that are going on for much longer, a cough that persists. For patients who've been more severely affected with COVID, required hospitalizations longer. Some of them may even require oxygen support a little longer. And there is a complex of symptoms which is called the long COVID. So a small percentage of people will experience symptoms going on much longer. That being said, there are some early indications that the use of the inhaled medication might reduce the incidence of the annoying long effects, which is the persistent cough, which causes a lot of anxiety and discomfort to patients. We were still waiting on data whether that's really a true effect or not.
Long COVID is not necessarily an outcome of over steroid medication. Am I right?
No, long COVID is not an outcome of steroid medication. What is a problem with excessive or injudicious use of steroids is secondary bacterial infections. So patients who will get other infections and then have a much more prolonged recovery and the after effects and sequelae of that extra infection.
Right. So, Dr. Pinto, so black fungus seems to be one of those, a secondary infection. So tell us about that. Everyone is quite worried about how it's spreading, and it seems to be caused by, again, medication or over-medication.
So that, alluding to the same study again, the recovery study used 6 milligrams of Dexa for 10 days. That's pretty much all they used. Unfortunately, there is this misperception that worse the disease, higher the dose of steroid required. Longer the duration of steroids required, that it needs to be tapered over a longer period of time. So there are two issues with steroids, right? One is that you start them too early. Number two is that when you do start them, maybe appropriately, you start them in too high a dose or you give them for too long a period. And that's the second problem that leads to secondary bacterial infections, secondary fungal infections that we have seen. We've lost a couple of patients who've come to us after being given really high doses of steroids at other hospitals. And then, you realize 2 weeks, 3 weeks down the road, because their immunity is suppressed to such an extent by those high doses of steroids, their lungs now become fertile ground for fungi to grow, for bacteria to grow. And yes, that is a real concern with using too high and too long doses of steroids. I think that's more a dose and a duration related effect rather than premature starting of steroids. So I think there are two separate issues which really need to be addressed.
Did you also say that younger people were being administered to a greater extent than older people?
So I mean that's a personal observation. I think a lot of us have seen that the younger you are, you tend to by virtue of the fact that your immune system is probably stronger, your immune reaction to the virus is more potent, you tend to have higher fevers which last for a longer period of time. And a young person having a high fever, getting anxious, therefore becomes, again, a kind of a person who the doctor feels very pressured to start steroids in. And this is exactly the group which otherwise would have just mounted fever for probably 10 days, maybe a prolonged period, but would have settled down quietly. But now, because they've been given steroids, they have a much more severe course of disease. And this, a lot of people talk about how younger people are being affected more severely this time around. It would be interesting to audit their prescriptions actually and see how many of them actually did worse because they were started on steroids too early. And I do hope somebody looks into that.
Right. And that was going to be my follow-on question. Dr. Bhat, your views on that? Younger people getting over-medicated, therefore maybe ending up in a worse state?
So I do think that there is truth to that, because younger people do have these robust responses where they're having these spiking fevers going 102, 103. And they're worried about it. Now, one of the other concerns that was there was that early on in the disease, we thought that the use of non-steroidal anti-inflammatory drugs was not a good idea in COVID-19, looking at some of the action of the virus on certain receptors in the lungs. We're 1 year into the illness, and we've realized now that these drugs can also be used as an adjunct to the paracetamol for the fevers. There was a time when we thought that no, those should be avoided as much as possible, because we were seeing patients coming in with kidney related issues when they had severe COVID. We've gone past that, so we know that we have other drugs in our arsenal before we need to turn to steroids, so we can stay limited in our use of steroids for that specific indication of oxygen dropping down. And of course we can be a little bit more liberal in terms of, okay, we tell the patients that walk around, see if your oxygen drops when your heart rate goes up a little bit, then that may be an early indication to start. There will always be a small group of patients who will benefit from early steroids or who will require prolonged steroids in severe COVID. But that's a much smaller number. The majority of them will require it only for that specific indication of low oxygen and for that specific duration of 10 days.
Right. Dr. Pinto, as we look ahead, what are the one or two good medical practices that we can apply to the extent that we can apply and also spread the word, particularly in the case of medicines and strong medicines like steroids?
So my prescription for steroids, based on the current knowledge of the literature, pretty much is inhaled steroids in the first week in a subset of individuals. It's one of those drugs which really doesn't have such a bad risk-benefit ratio. So even if you over-medicate, the likelihood of causing harm is quite small, since you plan on giving it for a really short period in any case. It's not prolonged use of inhaled corticosteroids. So the first week is paracetamol and inhaled corticosteroids. The second week, if the oxygen drops down, and we don't necessarily need to divide it by weeks, but towards the end of, say, 4 or 5 days, if the oxygen levels drop down at some point of time, that's the time you add corticosteroids. This is pretty much what you need to do at home if you're managing somebody at home. Things like proning, sleeping on your belly at home, is not a bad idea if your oxygen levels are borderline. We've created this simple infographic, which is available on indiacovidsos.org, which is available in multiple languages now, which pretty much summarizes what a person can do at home. We do realize that getting a bed in a hospital is not easy, and we do realize that some of the things we're doing at home may not have been things that we would have always done at home had beds been available easily. But I think you can still be very judicious, sensible, and turn around a significant proportion of your patients while managing them with these simple measures: paracetamol, inhaled steroids, oral steroids if necessary in the stage where the oxygen levels drop, proning as much as possible, and I think most individuals will turn around with this.
Okay, Dr. Bhat, going forward, how are you seeing this? And let me add another question to that. Do you think this requires some sort of regulatory intervention, or at least a guideline on when to use steroids? Maybe everyone knows it, but maybe people have slipped a little and need to be reminded.
I certainly think that having strong guideline statements from professional bodies will help a lot. I think that as pulmonologists, we speak to each other, it seems like in an echo chamber, since we're aware of the indications, and I don't see that kind of misuse. But we must understand that there's a very small number of pulmonologists for the kind of population that is facing this illness. And it has required the collaboration and cooperation of every other specialty. So it doesn't matter if you are an endocrinologist or if you are a cardiologist, you have patients who have COVID who are approaching you for advice. You have your physicians, your family physicians, everyone is treating patients with COVID. So there needs to be every professional association sending out its guidelines to its members, that this is how you use it safely. I completely agree with what Lance said about the best practices in the use of steroids and the simple things that we can advise patients about. One more thing that I've noticed is that, culturally, we're not people who go get annual health checkups even when we are in a certain middle-age group. Very often what we realize is that patients are diabetic and they've never known about it, and we're prescribing steroids. So the questions that we're asking them before we prescribe steroids in those patients where it's indicated is, do you know if you have any background diabetes or any other medical illnesses? And they'll say, no, not that I know of, but we will check it out and we will tell them to monitor. And that's when you discover that there was an underlying illness, another risk factor. So I think it's best practice also to check. Patients may not always know what their background medical condition is. So just using that illness as a way of checking in on background conditions as well.
Right. Last question, Dr. Pinto. As we maybe slow down on the second wave and start gearing up for the third wave, hopefully gearing up, that is, and hopefully not see a third wave. How do you think we could conceptually be approaching things differently? And this is a broader question. I mean, it's not about just the medicines that you prescribe, but how could we be just doing things differently, if that comes to your mind at all?
I think the only thing that has consistently shown a change in terms of prevention through the pandemic is vaccination. Mass vaccination, reaching people as quickly and as broadly as possible, I think, is our best bet at avoiding the next wave. The other thing that would be really useful is mass zero prevalence studies. If we direct the vaccination towards low prevalence areas and low prevalence individuals, I think we would definitely be able to prevent the next surge. So if you look at the Mumbai zero prevalence study, the last one had 57% antibodies in the slums and about 16% in the high rises. Had we paid heed to that, we would have realized that this time around, it's about 80 to 90% of the infections are happening in high rises, where there was only a 16% zero prevalence. So I think if we guide our vaccination towards these individuals who really need it the most, especially if there's vaccine shortage, I think we need to be smart about that. And I think that's our best bet at preventing the next wave.
Okay, Dr. Bhat, can I get a quick last word from you as well as you look ahead?
I think, I think that for me, my pet peeve is inappropriate mask technique and distancing. We tend to let our guard down with people that we know and are familiar with. And, I completely understand that it is uncomfortable and it is difficult to have masks on for most of the time. We're familiar with it. As pulmonologists, we've dealt with infectious diseases like tuberculosis, and we accept the mask as a very simple thing that will protect us. So I've seen that this time, the majority of people, we've seen infection spread amongst small groups of people who are familiar with each other, who trust each other's infection control practices. Oh, I know this person. I know that they're a responsible person. They're not going to behave irresponsibly. So I let my guard down in front of them. I don't think we can let our guard down in front of, we just have to, as much as we can get the messaging out on masks and distancing and hand hygiene, the simplest of measures, and as Lance said, like really approach vaccination on a massive scale. Those are the only two things that are going to be really protective for us.
Right. Dr. Pinto, Dr. Bhat, thank you very much for joining me. I do wish you and your teams all the very best in continuing this fight against this dreaded disease, and I do hope to come back to you soon as well. Thank you once again.
Thank you for having us.